Thank you very much, Dr. Bashar, for an excellent presentation. And now it's time for panel discussion. Floor is open for questions. Anybody would like to have a question, please go to the mic and then you can start the question. Perhaps, Dr. Bashar, I'll start with you. So you mentioned a lot of additional factors that could modify the risk score. But at the same time, one has to be cognizant about the practicality of this during a busy clinic. So any comments on this?
Well, I mean, yeah, I agree with you, definitely. Now, the available one, it takes not more than 2 minutes. So if you have 2 more factors or maybe less factor and so on, yeah, I agree with you, but still, I mean, you have to consider new factors, emerging factors.
Thank you. Dr. Tariq, please.
Thank you very much. Khalid, thank you for all speakers. And again, just would like to congratulate Mohammed for such a fascinating idea of this global survey. I think it has provided a platform of unprecedented sort of new insights. I think from what Khalid has mentioned, just actually going to be my comment to Bashar, which you have been leading a quite important, actually, this sort of risk calculation. I think with more information and more insights coming from other factors, there will be a need to consider sort of a more simplified approach. So it might be a good idea just to lump up, you know, several sort of areas into one. Just a thought. Thank you very much.
Yeah, thank you.
Assalamu alaikum. This is Muazzez Islam Faris. I would like to thank all the speakers for the invaluable presentations. My comment actually, it's a few comments from Dr. Wasai about the fasting effect on brain health. Actually, we have to, not to put all the fasting types in one basket. There are different types of fasting with different implications on the cognitive functions, on sleep, and so on. But I think there is a need for more like specific description. You mentioned that fasting improves, for example, sleep. Our meta-analysis and statistical reviews on fasting during Ramadan showed that the observance of fasting was associated actually with reduction in the sleep duration, sleep quality, reduction by about 1 hour of the sleep duration, increase the Epworth sleepless score, and all these were negative because actually fasting is not like just an abstinence from food, it's a kind of like a holistic change in the dietary and lifestyle behaviors that in the end affect the health outcomes. The same thing for the brain-derived neurotrophic factor, BNDF, which is a very, very important factor that affects the cognitive function, neuroplasticity, neuroinflammation, and the risk of developing cognitive function diseases. We found in our also statistical reviews that there is a mixed effects on the effect of for the effect of fasting, intermittent fasting regimens, fasting in Ramadan, on the brain-derived neurotrophic factor, and these were highly heterogeneous, actually, effects with variable impacts for different types of fasting. I think, yeah, this is my comment on only just to have more like specific description and not to generalize the effect of fasting on these important cognitive functions. Thank you so much.
Thank you very much. Actually, Dr. Wasai is not with us yet on the virtual. Thanks for the comment. Dr. Hassani?
Thank you very much. Just a quick comment on that presentation. It was an exciting presentation with lots of points about improvement in fasting, but I wasn't really sure about the evidence. I didn't really see any references or any information about the type of studies. But my question is initially to Riaz. You focus very much on your presentation on the differences with diabetic foot ulcers patients with neuropathy. What are your thoughts on the neuropathy group of patients? Do you think from reading the data there is a consideration for the person with neuropathic pain without ulcer? Did you feel it impacts their ability to fast?
I mean, I can only go on the data you provided, and you didn't differentiate painful from non-painful from the DAR 7. Maybe going forward, we need to do that to allow us to be able to dissect that out. I think there is a need for studies, particularly, I think it was the last speaker on brain health. He said something about burning feet improving with intermittent fasting. I don't know. Maybe we need to do a study over Ramadan to look at painful neuropathy, as we've discussed. You know, DM4 scores of before and after. Yeah.
Thank you.
I have a question to our colleague from Iraq. I think you mentioned a figure of 44% of those who had low risk on score that they did not fast. Is there a reason why this high percentage of people with low score and not fasting Ramadan? Is it like a personal beliefs, or what's the background?
Thank you very much for your very important question. Really, we are in the processing of data extraction, and we have really dig in this very big data, and there is no excuse for any patients with low risk to have such refusal for fasting. This is first. The second one, for those with low risk, they include also patients who were on no treatment at all. And no treatment at all, according to the DAR risk score calculation, scored as 0. And as you know, no treatment at all, either the patient neglected his treatment or the patient is very good in his lifestyle. That's why we don't have the exact answer for your question, and we may have such question answered in the next 3 months when we release the whole Iraqi study to the press release.
Thank you.
Just a quick correction, Dr. Sameh. The patient on no medication does not score 0, scores 0 for medication, but they can certainly score a lot on other issues, for example, complications and other aspects.
Yeah, absolutely. But if they have no medication, on their DAR risk calculation regarding treatment score, it's 0. I really talk about the treatment itself, not the complications, sir.
In my commentary or special communication in about 12 years ago now, I've spoken about the fiqh and medicine getting together, which is a very highly cited paper based on translation of some religious guidelines. But I have a point with the presentation of Sameh, which is the religious fasting that actually continues for 60 days. Other than the kuffara, there is no other religious fasting that continues for 60 days. So and I think as physicians, we have to fall behind what is required from the fiqh requirements. So for instance, we know fasting for Ramadan is between 29 and 30 days. But I think studying fasting that we impose on patients or on people to do for the sake of the studies is not very clear in my mind. So I would like Sameh to clarify what is the type of 60 days they have studied. Was it artificially imposed, or it is part of a religious practice?
Thank you, sir, for your very important clarification. In the study presentation, I have said that we don't have any rule in imposing any of our ideas on the participant, on our study participant. We are advisory rather than imposers. We don't have any part in decision making regarding the patient's decision in the fasting. We only treat them, advise them, and no rule at all for pushing them for any type of fasting. The patients who were fasting for more than 60 days, we included Ramadan as part, the 30 days of Ramadan. The addition came from pre-Ramadan and post-Ramadan. Although post-Ramadan they fasted less, but the before Ramadan, as you see in my, as you saw in my slides, it's too much. They fasted Rajab and some of Rajab and some of Shaban and all of Ramadan and some of Shawwal. The minimal fasting days for those with extended fasting was 60 days, while the maximum is 147 days. All of them came voluntarily for fasting. They like fasting these days, and we don't have any rule in interplay with them. Thank you.
If you allow me, Khalid, our colleague in ophthalmology, I have a question that might not be directly related to Ramadan in particular. In your practice, do you see any deterioration of retinopathy with this pandemic of using weight loss medication, diabetes drugs, which are now used as weight loss, GLP-1 receptor agonists? Do you see worsening retinopathy in your patients?
Right. I mean, the one major cause for deterioration during Ramadan fasting is the non-compliance of patients to come to the clinic to receive their treatment. Now, we do inject the patients with an anti-vascular endothelial growth factor. These are intravitreal injections given into the eye on a monthly basis. And most of the patients like to time the timing of their injections either before Ramadan or after Ramadan. But if they do fall during Ramadan, then they miss the treatment, and that eventually have a knock-on effect on the outcome and deterioration in vision after Ramadan. But as far as the medication is concerned, my main point of looking at these patients is their HbA1c, whether they are using the GLP-1 or whether they are on insulin or oral medication, is the HbA1c. This is the major factor for us, because each 1% reduction in HbA1c means 20% reduction in the risk of diabetic retinopathy progression. So that's a major factor.
Thank you very much, Dr. Ala. With this comment, we come to the conclusion of the session. I'd like to thank Dr. Yusuf for co-chairing the session, and also the excellent speakers with the insightful discussion. Thank you very much.